Good afternoon. Thank you all for joining us. Our project is on transitioning cancer follow-up care from specialized oncology teams to primary care providers. Our team is composed of myself, Alya Mohmood, Aflyn Amaleethan, and Gabriela Roselli Ferrari. We are all students part of the Translational Research Program at the University of Toronto, and we're so excited to be sharing our project with you. So cancer survivorship aims to holistically address the ongoing physical and psychosocial needs of cancer patients from the point of diagnosis and onwards. By year 2026, it is estimated that more than 248,000 Canadians will be newly diagnosed with cancer. Cancer survivors have unmet supportive care needs that may worsen quality of life. After treatment, these patients may encounter issues such as adapting to new lifestyles, fear of reoccurrence, and managing late effects from cancer treatments. Current literature shows that primary care providers are able to provide a holistic approach and optimal cancer survivorship care. However, some barriers that prevent PCPs from taking on a greater role include challenges in coordinating care with oncology teams, undefined roles and responsibility amongst healthcare providers, lack of formal training in cancer survivorship, and their hesitancy to provide follow-up care because of these issues. The Princess Margaret Cancer Center has identified barriers to survivorship care. Their oncology units are overburdened and do not have the capacity to take on new patients, as they are still seeing those in follow-up care. Considering these challenges, the leadership team has expressed interest in developing post-treatment care pathways where primary care providers from the community are integrated into their patients' survivorship care plans. Integrating PCPs like family physicians may ease the burden on hospital and allow cancer care specialists to focus on new patients receiving primary treatment. Many disease sites at Princess Margaret expressed interest in the project. However, only the head and neck clinic had the resources and a clinical nurse specialist to take this project on. The clinic expressed interest in implementing an end-of-treatment letter that they created to be sent to PCPs prior to discharge at 5 years post-treatment. The purpose of an end-of-treatment letter is to provide PCPs with information about their patient's overall treatment, surveillance plan for the next 5 years before discharge, and actionable items. The addition of this letter would essentially integrate PCPs into their patient's cancer survivorship plan before discharge. The clinic currently only uses a discharge letter. So this project was guided by the Toronto Translation Research Framework. It is a human-centered design research approach that aims to provide evidence and scientific findings into interventions that improve health. This research approach allows us to meaningfully engage with the end user from the beginning of the process to go develop an intervention that is impactful. And so the first step we took in our project is to discover the problem and whose need is it. We did this through contextual inquiry and speaking to several experts in the field. Our research question to guide us through this project was, how can communication between oncologists and primary care providers be improved to support PCPs in providing follow-up care to cancer survivors? Our first objective was to gather PCPs' perspectives through surveys on the current state and their needs when providing follow-up care. Our second objective was to gather feedback from PCPs through interviews on the end-of-treatment letter.
So now we're going to dive into our methods. Our project used descriptive mixed methods. A mixed method survey was created through co-design with PCPs and oncologists. This survey featured 7 multiple choice questions and 3 optional written responses. The survey aimed to gather PCP perspectives on the current state of communication and their preferences when taking on follow-up care. This survey also aimed to validate the need discovered in our contextual inquiry. Our project gathered additional qualitative data through semi-structured interviews. An interview guide created by our team was used to guide our conversations during 20 to 30-minute interviews on Microsoft Teams. These interviews aimed to gather feedback on the head and neck clinic's end-of-treatment letter prototype. The criteria for participant eligibility for the survey and interviews were family physicians who are licensed to practice in Ontario. For the interviews, we conducted one additional interview with a participant from out of province to expand our insights. The survey was distributed through the TRP Alumni Network, the Department of Family Community Medicine, the UHN Scope Group, the Muslim Medical Association of Canada, and the Ontario College of Family Physicians by email. A snowball sampling method was also used, in which survey participants were encouraged to share the survey link with their interested networks. For the interviews, a similar recruitment approach was taken, with a focus on recruiting from our existing networks. The multiple choice questions from the survey were analyzed on Microsoft Excel using descriptive statistics. The written responses received from the survey were analyzed using content analysis. Due to the lower response rate and short length of these responses, we immediately summarized the input rather than using formal codes. Interviews were recorded and transcribed on Microsoft Word. Interview transcripts were analyzed using content analysis. 2 team members were assigned to independently analyze each interview to ensure intercoder reliability. Codes were generated inductively such that they were created directly from the transcripts rather than being predetermined. The codes were then analyzed by the group and translated into categories. The survey received 28 completed responses and 1 incomplete response. The incomplete survey was excluded from analysis. The majority of participants practiced in a group setting. Also, the majority of participants have received no cancer survivorship training. So for the next few slides, we are going to focus on the results from a series of questions that ask participants to reflect on their current communication experiences. When asked if PCPs receive frequent communication from the cancer care team regarding their patients' diagnosis and treatment plans, 75% of survey participants selected this is often or always the case. This demonstrates that there is consistent information shared at the earlier stages of a patient's cancer care journey, but as we will see in the next few slides, information in the later stages is not always as consistent or relevant. When PCPs were asked to consider how frequently they receive a comprehensive discharge summary from the cancer care team, mixed responses were received, with 54% of survey participants reporting that this is often or always the case. Mixed responses were recorded when considering the receipt of an explicit follow-up plan from the cancer care team, with 36% of participants reporting this is often or always the case, and 39% reporting this is rarely or never the case. These inconsistencies demonstrate the need for standardization in the information shared between providers. Almost half of the participants indicated that they sometimes understand the division of care between the oncologist and PCPs. It is interesting to note that 39% reported that this is rarely or never the case. Lastly, in this series of questions, 5 participants chose to share written responses. In sum, these responses indicated that the level of communication differs depending on the cancer care team, with some participants reporting they receive too much information, while others feel they should receive more. Participants were asked to consider which time points they would prefer to receive information from the oncology team regarding their patient. This slide features a timeline that indicates these time points as well as their respective responses from participants. The 3 most common responses were at initial diagnosis, end of treatment, and when the patient is discharged. For initial diagnosis and discharge, there are already formal documents that get sent to the PCP. End of treatment is the only time point where there is no formal document being shared. To better understand what barriers are affecting PCPs when taking on cancer follow-up care, a series of questions asked participants to indicate the frequency of different barriers. The top 3 barriers that were reported to occur often or always were a lack of knowledge or training on monitoring tests for the late effects of cancer treatment, a lack of knowledge or training on the management of long-term side effects of cancer, and a lack of knowledge on prescribing and adjusting medication. These perceived barriers may suggest that PCPs have the general knowledge to take on follow-up care. However, they lack training in areas related specifically to post-treatment care. Participants were provided with 9 potential items to be included in a discharge summary, and they were asked to select the ones they would prefer to be included. The following items demonstrate the top 5 responses: recommended surveillance test and frequency, treatment summary, risk of late effects, recommended monitoring tests for late effects, and information on how to re-refer the patient back to the cancer care center if needed. While these were all popular preferences, recommended surveillance test and frequency was the most selected, with 93% of participants indicating they would like this included in a discharge summary. In a written response, participants shared that receiving more guidance on surveillance would be helpful. Interestingly, surveillance was a low reported barrier, and interpretation of surveillance test results received low preference for inclusion in the discharge letter. This may suggest that PCPs have the knowledge to interpret the tests, but they are unsure which tests to provide or do not have the time resources to surveillance. In another written response, one PCP shared that only certain information regarding treatment is necessary for them to know, and technical information, such as the radiation dose, is not needed. At the end of the survey, participants were given an opportunity to provide additional feedback that was not addressed. One participant highlighted that intense workloads and the lack of specialized knowledge were reasons that PCPs feel they could not take on follow-up care. This feedback was noted and shared with the head and neck clinic at a co-working session.
So this project contributes to the growing body of literature regarding the communication barriers between PCPs and oncologists when providing follow-up care. Current literature highlights the need for improved communication between providers, but it does not clearly define actionable measures to optimize the transition of patients. This work extends current literature by understanding the first-hand insights and challenges faced by primary care providers, which are not adequately captured in the broader studies. Surveys indicated that a top priority for family physicians was clear role definition and actionable guidance. The current communication tools provide inconsistent levels of communication, most of which do not align with the informational priorities of PCPs. These results inform the iterative refinement of an end-of-treatment letter by embedding the specific feedback gathered through interviews and surveys. In doing so, this project builds on existing literature to gather first-hand experiences and translate it into a refined communication tool for use by the head and neck disease site to effectively impact the communication between providers. In the interviews, 9 participants were interviewed on the validity and usability of an end-of-treatment letter. One participant from Manitoba was also interviewed as they provided the additional out-of-province context for our study. An interesting thing to note among our participants was the lack of formal training in cancer survivorship. Now, through the interviews, 4 major themes regarding the end-of-treatment letter were identified regarding informational needs of family physicians. The first major theme was formatting and style. Recommendations were made to revise the letter to better meet the needs of time-constrained clinicians who are already managing significant administrative workloads. An interviewee highlighted that the letter needs to be easy to read and quick to scan for relevant information. The prototype format of the letter was presented in long, dense paragraphs, which made it difficult for family physicians to identify key tasks, and in practice could lead to important information being overlooked. As a result, the letter needs to be short and concise with actionable items. The next major theme identified was related to the clarity and relevance of content. Given that family physicians receive many letters in their daily practice, the interviewees prefer content in the letter to be tailored specifically to their role as PCPs. The priority was the inclusion of new information and not existing information that they would already know about their patient's cancer care. So here's a statement that was made by one of our participants. In our interviews, we found that family physicians spend nearly 15 to 20 hours doing administrative work weekly, unpaid, in addition to seeing patients. They are past burnout. Now, this project recognizes that PCPs are overburdened. Family physicians play an important role in the provision of primary care that involves managing common illnesses, providing preventative care, and coordinating overall patient health. While we cannot change the workload in this clinical workflow with oncology teams, this project aims to facilitate better communication in a practical, systems-level way to make the patient transitions more manageable. The third major theme identified was the importance of actionable items for PCPs. Family physicians need to know which responsibilities are transitioning to primary care and which will remain with the oncology teams. The interviewees highlighted that there are undefined roles and responsibilities among healthcare providers in cancer care, which make it difficult for family physicians to support their patients effectively. Including a checklist with clear, actionable expectations in the letter would help guide family physicians in delivering coordinated care. The last theme identified was the effectiveness of communication channels with oncology and other multidisciplinary teams. Family physicians would like to be able to contact the oncology team with questions regarding their patients' follow-up care. Many suggested a single point of contact, such as the nurse navigator, who would have access to the information they need and who could assist in coordinating access to multidisciplinary services. The interviewers also indicated that including the purpose for certain multidisciplinary services would be important. Patients often do not remember the names of all the specialties involved in their care, which makes it essential for the family physician to be informed about the members of the care team and their specific roles as the primary point of contact for the patients. So here we showcase another statement that was made by one of our participants. It highlights the dynamic nature of cancer survivorship care and the importance of clear communication and guidelines. It is important here to clarify that while the project aims to revise an end-of-treatment letter prototype to support communication, a single tool solution cannot resolve the systemic communication challenges in the transition of cancer survivorship care. And so now, going back to what Alya previously mentioned, the project was guided by the Toronto Translational Framework. In the next section, we will discuss our impact and what same steps we aim to take to apply the intervention to support the clinical workflow. Before we get into that, we'd like to show you the clinical workflow with a patient at the end of treatment at Princess Margaret. As patient enters the end of treatment stage at the head and neck clinic, there is still typically a surveillance period of 5 to 10 years before the patient is fully discharged from the oncology teams. In this transition period, the clinic aims to implement the end of treatment letter to support the family physician's understanding of their shared care role with the oncology teams. At this stage, it is important to have clear and consistent communication to ensure the best healthcare outcomes for patients. Our group has chosen to support the clinical workflow by translating our work into 3 main resources to create impact. In the co-working session with the head and neck clinic, the discussion further explored how the revised treatment letter could address formatting issues and content miscommunication seen in interviews. It also sparked the conversation on the feasibility of integrating a letter into an electronic health system. Following this session, an iteration was made to the end of treatment letter and shared with the clinic. This consisted of revised formatting, information organized into charts, and dedicated resource sections to support the PCPs in the management of patient symptoms. And now, for meaningful engagement with other oncology teams, the end of treatment letter feedback was used to create a guide that outlines how to address communication barriers with PCPs. It outlines how oncology teams can improve care transitions by providing clear, concise, and standardized end of treatment letters tailored to the needs of PCPs. This highlighted key communication challenges, essential letter components, and co-design insights to support effective information sharing and role clarity in follow-up care. For our research to drive meaningful change, it must also be translated into actionable knowledge and delivered to providers of care. Our team has 3 main goals to further disseminate our findings. The end of treatment letter prototype is generalizable for implementation with other specialized cancer care clinics at Princess Margaret. We aim to meet with the other site leads in specialized clinics and publish our guide to the PM intranet, where it will be accessible to other clinicians as they are the makers of change in this workflow. We also aim to attend the Canadian Cancer Research Conference 2025 and to publish our findings in the Journal of Primary Care and Community Health. In a complex system of healthcare, there are many factors that impact clinical workflows. So by showcasing our work to other providers, we aim to encourage future QI projects that focus on the user's needs.
Our team recognizes some limitations to our project. So the sample size and feasibility were constrained by the 1-year project timeline. We faced some challenges in recruitment, and social media was not used. The scope of the project focused primarily on family physicians, but it is important to note that in primary care settings, patients, nurses, and allied health professionals are also involved in clinical workflow. Engaging clinicians to collaborate on the project was also very difficult. Many clinics are already overburdened, and at the end, our team worked with the head and neck clinic because of resources. Lastly, there are notable technology limitations to the implementation of the letter prototype across all clinics. Some family doctors still use the traditional fax system. So we built on key competencies throughout the project. For example, persuasive communication, how to effectively speak to clinical teams and persuade them to believe in our methods and our project. We had to use creative problem-solving skills and introduce a TRP framework to the clinical team at Princess Margaret. And lastly, we collaborated with a large clinic at the nation's largest cancer hospital. And this concludes our presentation. Thank you so much for your time and attention. A special thank you to our supervisors, Adita and Joseph, our project advisory committee members, Daniel, Carolyn, and Anne-Marie, as well as our collaborators at Princess Margaret, Jennifer, Christian, and Alex for all your support.